Welcome to the OMM Medicines module on leukemia in under 10 minutes. So the leukemias can be very challenging for students because they have very similar names such as CLL, ALL, CML, and so on. And so because of this, we've organized our flowchart to characterize the different leukemias based on one very characteristic presentation aspect or one very unique feature that they may have. So let's start by talking about some of the common features to all of the leukemias. The most characteristic is going to be a very high white blood cell count, sometimes even in the thousands. They'll also have non-specific features such as malaise, fatigue, fevers, and weight loss, which whenever you see weight loss in a question stem, it should raise a concern that the patient may have a malignancy, and so that should be on your differential. Patients with leukemia can also have an enlarged and palpable spleen, lymphadenopathy, and then drenching sweats as well. So if a patient presents with all of these features, it should raise a flag that maybe you're dealing with a leukemia. And the next question you should ask yourself is the patient young, meaning are they under age 30, or are they about age 60 or older? So let's say our patient is young. After that, we need to ask ourselves, is the patient very young, meaning under age 10, or are they an adolescent, meaning over age 10? And so if the patient is under age 10, it would raise concern that they have BALL or B-cell acute lymphoblastic leukemia. So as we just mentioned, BALL is going to be associated with much younger children. It will be TDT and CD10 positive. It has a much higher prevalence in children with Down syndrome. It will have either the translocation of 922, which is your Philadelphia chromosome, or your T1221 translocation. And then a key fact that you need to remember about BALL is that you need to treat the sanctuary sites, which are the CNS or the testes, which is out of scope of this video, but it is something you need to remember for treating children who have BALL. And one of the key ways to remember this is that young children play with balls. Now let's say the patient is older than age 10 but younger than age 30, so perhaps they're in their 20s. Well, this would be more indicative of a T-cell acute lymphoblastic leukemia. So these patients commonly present with mediastinal masses, and they will be CD10 negative because remember, this is a T-cell cancer, not a B-cell cancer. And you can remember all of this with the three T's: T cells, thymomas, which are your mediastinal masses, and then teens. And you can also remember it by saying that older kids are tall, which stands for TALL, as we just mentioned. So BALL and tall are going to be the two types of leukemia that are predominant in younger people. So what if we have an older patient? Well, the first thing we need to ask ourselves is, are there any blast cells present? And if the answer to that question is yes, then we know we're dealing with either AML or a subtype of AML called APML. These patients will have a translocation between chromosomes 15 and 17 that commonly affects the retinoic acid receptor. They'll have auer rods in their cells, which is a great test question, and you should be familiar with how auer rods look. And they commonly present in DIC. So an elderly patient who presents to the hospital in DIC, you should be considering AML or APML in the differential. And the reason for that is because the auer rods contain MPO or myeloperoxidase, which can trigger DIC. And the treatment for these patients is going to be ATRA, which stands for all-trans retinoic acid. So a quick way to differentiate between the two types of leukemia we've already spoken about is to first see if they have blasts, and then if it is a young patient, it is probably ALL, and if it is an elderly patient, it is probably AML. Now let's say we have an elderly patient who has no blasts on the peripheral smear. Well, the next thing we should ask ourselves is, are the basophil levels significantly elevated? And if the answer to that question is yes, then you are likely dealing with CML, as an increased basophil level is very, very specific for CML. These patients are going to have the translocation between chromosome 9 and 22, just as we saw with BALL, and remember that that is referred to as the Philadelphia chromosome. They also have something called the myelocyte bulge, and a feared outcome of CML is blast crisis, where the blast cells make up more than 30% of the cells seen on a peripheral smear, and this can cause an enlarged spleen and many other bad side effects that can be very detrimental to the patient's health. And these patients are ultimately going to be treated with tyrosine kinase inhibitors such as imatinib. Now, if we have an elderly patient who does not have many blast cells and their basophil levels are not significantly elevated, we then need to ask ourselves, what is the lymphocyte level? And if the lymphocyte level is greater than 5,000, we're probably dealing with CLL, and if the lymphocyte level is less than 5,000, we're probably dealing with SLL, which is just a variant of CLL and is really just determined by the number of lymphocytes present, as we just mentioned. And CLL patients will have smudge cells on a peripheral smear, which you should be familiar with how those look. They will have low immunoglobulin levels because the white blood cells they're producing are not functional in the traditional sense. And then the feared outcome of CLL is the progression to diffuse large B-cell cancer, which has a poor prognosis. Now, there is one type of leukemia we didn't mention on the previous slide, and that is called hairy cell leukemia. It is called that because the cells look like they have a bunch of hair sticking out of them. If you're not familiar with how that looks, you should look up an image of it. And this is going to be seen in adults. And one of the key characteristics is that when trying to diagnose a patient with hairy cell leukemia, you will commonly do a bone marrow aspiration. And when you perform this, it will be a dry tap, meaning that you did not get any of the tissue that you wanted. And that's because the bone marrow has mostly been obliterated. Another common finding in patients with hairy cell leukemia is massive splenomegaly. Now, I know we mentioned splenomegaly is a common finding in most of them, but if it is extremely large, then it would raise suspicion for hairy cell leukemia. And then the last finding is that it is also TRAP positive. One other topic we need to discuss is the Leukemoid reaction, which is a normal response of the body to infection. So if we have a patient who has an elevated white blood cell count, we need to know if the white blood cells are there in response to infection or if they are there because of the leukemia. And the way that we will do this is by looking at two labs. Those are going to be the LAP and then the myelocyte level. So LAP is an enzyme that's only found in neutrophils that are responding to infection. So if the LAP is high, then we would have an infection. If the LAP is low, then we would know that that's going to be some sort of leukemia, most commonly going to be CML. The other lab is the myelocytes, and as we already mentioned, the myelocyte bulge, and this refers to the proportion of metamyelocytes to myelocytes. And so if you have a higher metamyelocyte level relative to myelocytes, then that would be indicative of infection, and if the metamyelocytes level were less than the myelocyte level, then that would be more indicative of CML. I'll finish with one slide on the treatment for the different types of leukemia. For AML, the treatment will be chemo, and then some forms can be treated with ATRA, which is that vitamin A derivative. For ALL, the treatment is very complex, but typically consists of a combination of the three drugs listed here. For CLL, the treatment is going to depend on the severity of the symptoms. So if the patient is having only mild symptoms and they don't have any bone marrow failure or massive splenomegaly, then you do not have to treat them. If they do have any severe symptoms, then you will treat them largely with chemo, although there is not a single drug that is more effective than another. And then for CML, the treatment is largely going to be with tyrosine kinase inhibitors such as imatinib. And that is the end of this video on leukemia.